Thank you for agreeing to share your experiences about HIV treatment continuity and racial disparities post incarceration. My name is Kirsten Moore. Please introduce yourself to the people.
Hello, my name is Derek Webb. I am an MPH candidate and health equity scholar at the Brown University School of Public Health. And I am also a former White House rising leader for the Biden-Harris administration for HIV and response.
Okay, and could you tell us a little bit about your experience with the HIV response in the Biden administration?
Absolutely. One, thank you for having me today.
Of course.
I think my time at the White House working under the Biden-Harris administration for HIV response was definitely an enlightening one. Now that we're making advancements in treatment for HIV prevention and care, trying to get the treatment for PrEP, pre-exposure prophylaxis, medication that can prevent HIV, and also medication like Biktarvy to those hard to reach communities. So that's been the focus and goal of ours.
Okay. And when you say hard to reach communities, are you referring to Black and Brown communities, Latino?
Yeah, definitely. Our BIPOC community, so our Black, Indigenous people of color, those hard to reach communities, such as those rural areas where insurance like Medicaid and Medicare is not easily uptaken due to like systemic problems and also just the knowledge gaps.
Perfect. Thank you so much for sharing that information.
Yeah.
So, I have some questions for you to address health disparities experienced by returning citizens from the carceral system, as well as collaboration with healthcare providers such as yourself.
Mhm.
And I want to start with you telling me about your knowledge on health disparities within the Rhode Island Correctional Facility.
Yeah, thank you for that question.
Mhm.
I think that's a very much reflective question when we talk about health disparities that exist within the correctional system because people who are incarcerated are 3 to 5 times more likely to acquire HIV than their non-incarcerated counterparts, and that's due to like systemic barriers such as stigma and discrimination that shows up. Because while people who are incarcerated experience all these compounding factors like the stigma and discrimination, also accessing healthcare treatment in prison, when they are released, they have difficulties accessing primary care services. Also, some of them have committed crimes that deem them as felons, and because of political chaos and political jargon, what's happening, they're deemed not eligible for services like Medicaid and food stamps, and also applying for jobs. And sometimes jobs seeking people to care in terms of dental insurance and health insurance. And because they're not eligible for those positions, they don't get those services. So we do see a lot of people who oftentimes return to the prison system in hopes of accessing primary care services. Because the interesting thing about being incarcerated is that you do have access to routine care services. You have behavioral health resources. There's a dentist in the prison system. Some people can get 3 meals a day. They choose to go eat. They have rec hours and stuff, but it's just because working with correctional officers, they're looked at a little bit differently, experiencing that stigma. But when we talk about HIV and the care response in the correctional facilities, there's already a stigma associated with that. So I've worked specifically with populations who identify as MSM or men who have sex with men, and people who inject drugs, where we deem them as PWID in the acronym. And those two different communities experience stigma of compounding factors because they are people who inject drugs, and some of those people are experience homelessness. Some of those people experience food insecurity, shame from their communities, their families, and they're also social isolated. And we're working with MSM, men who have sex with men populations. They're experiencing this compounding factor of being the part of a community that's looked down upon because there are men who have sex with men, or they deem themselves as gay and bisexual or pansexual, whatever their identity is. And because they have those experiences, people in the correctional facility don't want to be associated with them. And because they don't want to be associated with them, they tend to feel that internal shame of themselves, or they're ashamed to just go get health care.
Thank you so much for giving a voice to the people who don't really have a voice within the
Mm-hmm.
systems that they exist in. So, what structural or systemic factors most contribute to disparities in treatment access for Black and Latino people post-release?
Absolutely. I would say specifically in the correctional facility, you have to work with the correctional officers. Sometimes you have to work with discharge planners to get to wherever you're going to go next, but also identifying what specific resources are for specific populations. And specifically with those Black and Latino communities, um, everyone in the correctional facility, in terms of staff, are familiar with resources specifically for them. So you're not gonna send them resources that, for example, yes, it can be a holistic LGBTQ plus clinic, but if the LGBTQ plus clinics are predominantly white people and you're sending Black and Latino communities there, they have to go through this racial compounding experience of, do I feel like I belong here? I identify with a certain population, but also I don't identify with the population they're kind of serving.
Mhm.
So that's something we do see a lot. Um, Also, some people have definitely mentioned wanting to get on health insurance, but also wanting to receive food stamps. And people in the correctional facilities sometimes are not fully knowledgeable about that. So they have to deal with this entire hurdle of, who do I go to?
Mhm.
It's not easily accessible for them. We're not making it to the point where here's your claim paperwork, here's the healthcare navigator. We're going to call you the next day to get you linked to some type of system of care, some system of housing, some system of just eating food.
Mhm.
So I think if we just mitigate those different, put all the responsibility on you to find your own services, then we will see those Black and Latino communities accessing those resources.
Thank you. It sounds like you brought up some barriers that exist with trying to navigate post-release for
Mhm.
these people within the community. And so, what are the biggest barriers formerly incarcerated individuals face in continuing HIV treatment after release?
Absolutely. As I mentioned before, it's primary services,
Mhm.
primary care services specifically. So people who are incarcerated, some of them do experience drug use. So they injection drug use specifically. So they do have access to treatment like Suboxone and methadone. They can get that. We call it MAT, medicated assisted therapy. So they typically go to a clinic where they can continue that treatment for that. But the primary care services, some primary care services aren't offering that medicated assisted therapy or MAT,
Mhm.
but we're trying to find a way where they can get routine care.
Mhm.
If they can get routine care, that will like mitigate a lot of the health inequities that they do experience. So I will say that primary care and also housing stability is a really big thing that we hear a lot. Working in the correctional facility is like, some of our patients are living in tents. I don't know if you know the term tent city
Mhm.
or tent communities, where they're living in tents all together, and that's not feasible, especially long term. So linking them to housing stability and also primary care services.
Okay, thank you so much for sharing that. And I want to ask a little bit more. You spoke on stigma earlier. How does stigma around both incarceration and HIV affect treatment seeking behavior in Black and Latino communities?
Absolutely, and that's like such an expansive question and also expansive response. So you have to think about it in a twofold way. You have the stigma of incarceration. You have the stigma of HIV. HIV in itself is not a biological, um, because you can still get HIV, but there are treatment out there to prolong your life. You can have a very healthy and sustainable life with HIV. So that's something you want to like really clarify. You get on your treatment, take your daily medication, whatever regimen that looks like for you. You can live past 80 years old if you take care of yourself and eat nutritious food and all that stuff and exercising regularly while taking medication. Um, it's not a death sentence anymore. But I think why some people think it's a death sentence is because of the social stigma. And something that I heard before in some literature, an STD, not a sexually transmitted disease, but a socially transmitted disease.
Mm.
So I think because HIV is so socially stigmatized, people who do have HIV or people who are at risk of acquiring HIV don't feel supported and they don't feel to the point where they can be authentic and also truthful when they're talking to their physicians. So I think that's where we have to address the whole culturally competent and culturally congruent care when you're dealing with a population who are at risk of HIV and who are living with HIV. But if you bring in that incarcerated factor, again, that social stigma. People who face incarceration are already stigmatized by the correctional facilities. They're treated as less than. Some of them are not given necessary care that they deserve, and that's a problem within itself. But if you add that compounding factor of experiencing incarceration while also at risk of HIV, you have for some people these triple and double marginalized identities where they're oppressed in the community. And as I mentioned before about accessing services like Medicaid, also housing stability, even accessing primary care services, I think there are questions that ask, or even a job. Have you been a warden of the state or something like that, or prisoner of the state, excuse me, or have you been formerly incarcerated? And just having that question on demographic screening form is already stigmatized. It's like, wow, this is something I have to answer. If I check that, are they going to hire me? Are they going to treat me with the fullest extent of care? So I think that's just something that we have to kind of mitigate. I, to some degree, feel like we should kind of take that question off because regardless of the crime that I committed, I've been released from prison. I've done my time. I do want to be a law-abiding citizen, and I also want to contribute to wherever field that I go to in a meaningful way. So if we just do those small things, and also everyone's human, treating them with compassion and care. But I understand you can't teach compassion, you can't teach empathy. So that's the problem that we're going through now with society.
Yeah. Thank you. Such a beautiful response to an extensive question. If we could just take a pause for a second and switch seats, that would be perfect.
Yeah, absolutely.
So how effective are current discharge planning programs in ensuring continuity of HIV care?
So in terms of HIV care, if a patient or detainee is already on HIV while incarcerated, of course, they do take their medications while incarcerated to maintain their undetectable status. So if you're undetectable, you're untransmittable. So U equals you. And that's something we're trying to be very vocal about is emphasizing that U equals you, that if you're undetectable and you cannot transmit HIV, you need to share group. So that's the most important thing. So if you're already on HIV medications and we're getting released back into the community, we try to make sure that you can continue your undetectable status, but also ensuring that you are getting linked to some type of clinic post incarceration. So we referred many of our patients to Open Door Health. So Open Door Health is a LGBTQ plus clinic here in Rhode Island. I think it's the only LGBTQ plus clinic in the state of Rhode Island that treats specifically LGBTQ plus populations. Not saying that they're going to treat any other population, but their cost is to treat LGBTQ plus populations and also do gender affirming care, HIV care, anything that falls under the spectrum of that. So we try to link people to Open Door Health immediately. We identify clinics and resources that will tailor to their HIV care continuum, such as Open Door Health, because we know that it's a clinic dedicated to the needs of populations who are incarcerated, who are MSM, who are people who take drugs, anything under that umbrella. We'll send them to Open Door Health, and they tend to get continued upon that care because we want to make sure that they maintain their undetectable status. So that's something we're linking people to. There's other methadone clinics here that we're linking people to care. Even harm reduction, we're linking people to harm reduction services like Project Web, we're trying to link people who are incarcerated to those services post release. But again, it's only so much that we can do on our end. It's still up to the patient that's being released to continue their treatment care. But we do, to some degree, follow with them because people who work in our clinic sometimes work with those at Project Web Arena, who also work with people at Open Door Health.
Okay, good. It sounds like there is a community that helps make sure that things get done and people are getting the care that they need. So that's good. How is access to antiretroviral therapy typically managed for those transitioning out of correctional facilities?
Yeah, thank you for that question. So typically what we try to do is, as of right now, um, intraviral, intraviral medications are likely targeted for HIV care. Um, Mostly some people do get a form, it's an appeal form where they can just they start on it while they're incarcerated, continue to be on it while they're incarcerated. They're coming in on HIV medication while getting into the prison system. Once they're released, we'll try to give them some type of dosage of medication, like pill forms where they can continue it. If they don't have access to it, if they don't have set plans or access to it beyond release, we'll try to give them a prescription of it, or they can go pick it up at a pharmacy if they're running out already on our end. So that's what we are currently doing, just ensuring that they're continuing that medication because it's very crucial, especially in post release, that you maintain your daily regimen because your viral loads can spike back up. So we don't want to miss any critical moment of post release to ensure that they maintain their medication and treatment, especially for those who are living with HIV.
Thank you. And are there culturally specific interventions that have been successful in reducing disparities in HIV care post incarceration?
So I would say, in terms of culturally specific, I can speak more to the LGBTQ plus populations because I do think there has been a lot of emphasis put on people who are of the LGBTQ plus community linked to care. So we'll send them to Open Door Health. For those who identify with the injection drug community, we'll send them to Project Weber Renew. As far as like culture, even though we're all advocates for harm reduction, there are people who identify as, and then I inject drugs. That's who I am. Thank you for sharing that information with us because it's a part of who they are and it's the culture. They have a culture of people they inject drugs with. So we'll send them to Project Renew. We'll send them to harm reduction clinics, overdose prevention centers, so that they can be able to engage in those harm reduction services. Also, as I mentioned, LGBTQ plus population, Open Door Health, as far as like culturally relevant, culturally sensitive, and culturally tailored intervention. Excuse me, culturally relevant, tailored interventions. Those are the ones that come to mind. But if you're speaking in terms of racial and ethnic, not a lot. There are some clinics that do see a higher percentage of immigrant populations, also Spanish speaking populations, and for example, Cape Verdean populations. There are Blackstone Valley Clinic here. I think in Pawtucket, if we have a a patient who is Cape Verdean, we're probably going to refer them to Blackstone Valley Clinic because they see a large amount of Cape Verdean populations. So that's what comes directly to mind in terms of those culturally specific and culturally relevant tailored care.
Okay, thank you so much for all of those resources. And now we want to switch to more of a community-driven solution for increasing HIV prevention treatment options post-release. So what role can community-based organizations, such as the ones that you've listed, play in educating formerly incarcerated individuals about their HIV treatment options?
Yeah, absolutely. That's a really good question. So we try our best to inform them of their options while they're incarcerated and also beyond incarceration. And we're trying to work with the discharge planner so that they can get some type of communication to that clinic or a community partnership that we're working with. And that's currently one study that we're doing is where we're trying to, based off the participant or the patient in our study, link them to a specific resource that tailors their needs. And based on what they're sharing with us, we're going to give that to the discharge planner, and the discharge planner work to identify those specific resources for community partnerships so that they can access them to make it easier for the person who's incarcerated that's going to experience the post-release period pretty soon, because that post-release period is very critical in terms of continuing HIV care and also getting on HIV prevention care. In terms of community partnerships, as I mentioned before, the clinics, like Open Door Health and Project Upper Renew, resources like Project Upper Renew, our harm reduction services and overdose prevention centers, and also the Blackstone Valley clinics. We're trying our best to where it can be more clinics that are accessible for these communities. But also, when they do see people who are incarcerated, it's not about the crime they committed, but also recognizing that you were once formerly incarcerated. We're not going to treat you or stigmatize you in this way. It's a matter of getting you on whatever treatment or care plan that you deserve and also need.
Yeah, it's definitely important to give people the help that they need in the case of HIV treatment. So I appreciate that.
Yeah, no problem.
And my final question for you is, what policy support is needed to fund and sustain grassroots programs focused on PrEP and PEP uptake post-release?
Yeah, so I was working in the policy space is multifaceted.
Yeah.
Also, it requires a lot of advocacy. Also, it requires people who are willing to put a lot of effort and time into advocating because while we're on the grounds running, these people deserve the necessary treatment and care. I think what's interesting is that we have to plead our case as to why people who were once incarcerated, people who are currently incarcerated, why they need care. When I think that's just, to me, healthcare is a human right, and it should not be based on zip code and socioeconomic status. Everyone should be getting justice-centered care and equitable health care. And it's the fact that we're telling policy makers this as if they should already know this. Like, you should already know everyone deserves equitable health care. But where we're in a climate where equity is under attack, inclusion is under attack, diversity is under attack, I'm all about narrative sharing where people who are incarcerated can share their experiences to policymakers. Because once they are released into the community, as I mentioned before, they are contributing meaningfully to their communities. So that's something we're really trying to emphasize now is that these people need care, they need equitable care, and they need justice centered care, and they need care from people who are going to be culturally competent, culturally sensitive, and also culturally congruent, despite where these people are, crimes are committed, where they're coming from. And that's something, as I mentioned before, you can't teach compassion, you can't teach empathy, but we can advocate for policies where they do get the necessary standard of care. You may not like them, but by law, you need to be practicing that standard of care. And that's what we're really trying to advocate for is that also teaching on the other end, do people know what standard of care looks like for them? Can they advocate for themselves? So that's a lot of things that we're trying to work within the correctional systems where people can self-advocate for themselves once they're released into the community. It's like, can you identify what standard of care looks like for you? Also, can you speak up for yourself when your provider is not doing the necessary job that they should be doing to make sure that you get the necessary standard of care that you deserve?
Right. And is there anything that we haven't discussed about your experiences with HIV treatment continuity and racial disparities post-incarceration that you feel is important for us to know?
I think we covered a range of topics, but as I said before, I think we should definitely approach people with compassion, empathy, and care, especially folks who are part of a stigmatized demographic, because we wouldn't want to be stigmatized ourselves, but also ensuring that they feel comfortable and that they feel seen and heard.
Treat people the way you want to be treated.
Absolutely.
I think that's the best way to wrap that.
Yeah.
So thank you for coming and speaking with us about your expertise in HIV treatment continuity and racial disparities post-incarceration. Derek Webb, everyone. Yeah.